Uh, Good evening, everyone. I welcome you all for our next What with Expert session. And today we have an interesting talk on Rasmussen's encephalitis, practical issues in the diagnosis and management of Rasmussen's encephalitis by another Dr. Suresh Pujar. I request our President Shafali ma'am to introduce the speaker for today, the expert and the moderator for today's session. Over to you.
Thanks. Welcome to this 68th webinar, and we will be having our speaker, the lead speaker today is Dr. Suresh Pujar. Can I have the slides, please, Asmita? So, uh, he's consultant pediatric neurologist at the Great Ormond Street Hospital, London, UK, and honorary lecturer at the University College of London, UK, and chair for the British Pediatric Epilepsy Group, and chair for the UK Pediatric Epilepsy Program Board. And his areas of interest are status epilepticus, fires, Rasmussen's, complex epilepsies, epilepsy surgery, ketogenic diet, and transition. And we have been collaborating and attempting to collaborate on fires for some time. And the experts for today are Dr. Atin Kumar, dear friend and colleague. Who are all neuroradiology is with Dr. Atin for so many years, and he's a great teacher and a great professional, and he has interest in pediatric neuroradiology, trauma radiology, and interventional radiology with over 276 articles and lots of very distinguished career. And we have Professor Maya Thomas, a dear friend, a professor and head pediatric neurology at CMC Vellore, and she has an area of interest of pediatric neurology and epilepsy, and they had a case series of Rasmussen's encephalitis also. And then we are very happy and grateful that Professor Ibru Arhan has joined from Turkey. She is in the Department of Pediatric Neurology, Gazi University School of Medicine, Turkey, board member of the Turkish Child Neurology Association, co-leader Pediatric Epilepsy Subsection, Gazi University Pediatric Neurology and Department Epilepsy Center. An area of interest are epilepsies, dietary therapies in intractable epilepsy, neurostimulation, and epilepsy surgery and sleep disorders, and has more than 100 research publication and a lot of laurels to her credit. And for moderating the session today, we have our own alumnus, Dr. Sachendra Badal, who is in the Army, and he's a pediatric neurologist and Department of Pediatric Command Hospital, Chandi Mandir, Panchkula, Chandigarh, Tri-City. And he, as I mentioned to you, he's our alumnus, and his areas of interest are epilepsy, neuromuscular disorders, neuroimmunology, pediatric movement disorders, and has 32 publications. And for his dissertation during DM, he got the ICNA Young Researcher Award for 2020 for his work on SLDs. Over to you, Badal.
Yeah, thank you, ma'am, for giving the opportunity. Now, without wasting any time, we would like to start the session with our guest speaker, Dr. Suresh Pujar. Over to Dr. Suresh.
Thank you. I hope you can see the slides.
Yes, very much.
Perfect. All right. So good evening, everyone. So I'm going to talk about diagnosis and management of Rasmussen encephalitis. And basically, the purpose of the talk is to highlight some of the practical difficulties in managing this rare but very difficult group of patients who have significant epilepsy and other neurocognitive difficulties, as we will go through. So these are my conflict of interest. So I'm going to start off with an illustrative case, kind of highlighting the difficulties in managing these group of patients. And then we will kind of discuss a bit about diagnosis of Rasmussen's, and then medical management, surgical management. We've got some data on longer-term outcomes, which I'm going to share with you. And then finally, we'll talk about what are the challenges and a bit about future work we're planning to do within our team. So I'll start off with this case. So we have we had this 16-and-a-half-year-old girl with no previous difficulties, was born in good condition. There is no relevant family history. Early development was normal, and she was right-handed. So she presented at age of 5 years with what was described as generalized convulsive seizure. Subsequently, she started having focal seizures with bilateral evolution, And initially, they were happening about once a week and from sleep. Very quickly, there was a significant escalation in the number of seizures, and it reached a point where she was having about 100 seizures per month. So very, very frequent seizures on a daily basis. And in addition to the seizures, she had progressive loss of motor function of the right hand with difficulty writing with seizure exacerbation. And subsequently, over time, there was kind of the epilepsy kind of became more mature and declared itself in that she was having right-sided onset seizures. And when she got to about 11 years of age, she started having drops because she was going stiff during these seizures, and she was having 2 to 7 drops per day. And some, if she was not held quickly, she would fall and have injuries. And a year later, there was further deterioration, and she was having very frequent focal seizures, increasing motor deficit. Now she was starting to limp, and she was swaying more towards the right side. And the family also started reporting that she was having difficulty with language. So these are the seizure semiology. The first type of seizures were frequent focal clonic jerking of the right arm and leg, and this was almost continuous on and off during the day with preserved awareness, what we would call as EPC, epilepsia partialis continua. And she would have these episodes lasting for about an hour. So there would be times when she would have them daily, multiple times a day for a few days or weeks. Then she might have a bit of a break for a few days, weeks, and then she would go on and have more EPC again. The second type of seizures were what the parents described as big seizures, in which she would start off again with the right side, and then there would be bilateral tonic-clonic evolution. These were short, lasting for up to 3 minutes, but then she was having 5 to 8 of these seizures every day. And the third type are the drops, where she would suddenly either go stiff or lose tone and then drop. And again, they were happening several times a day. So early development was normal. She was fine until the age of 5 years. And then, as I mentioned, she had progressive decline in her motor function on the right side. When she had her neurodevelopmental assessment done at 12 years of age, she had a persistently discrepant profile in that she was broadly average non-verbal abilities, but her verbal abilities were exceptionally low, implicating that it was the left hemisphere dysfunction that was causing the problem. And although she wasn't really having regression of her skills, she was not making any progress. So essentially, she was had a plateauing of her developmental skills for a few years. I told you initially she was right-handed, and by the time she got to 12 years, she became left-hand dominant. So her function of the right hand was getting worse, and she started using left hand more and more, and then she was predominantly using left hand. So she had right hemiparesis, including right facial weakness, and she was losing her ability to kind of use finger movements on the right side. She had reasonably good speech and was able to speak in sentences, but there were some difficulties with her language fluency, which was kind of noted when she had a language assessment done. And she did not have any visual field defect at this time. So I'm showing you 2 MRI scans. One on the left-hand side was a scan from 3 years after epilepsy onset, and the one on the right-hand side is the scan 4 years later. What we see is a progressive kind of atrophy of the left hemisphere with atrophy of the caudate, and then you can see the prominence of the sulci and Sylvian fissure on the left side. She had EEGs done, and the data from video telemetry showed that there was significant asymmetry of the background with slowing and discharges over the left hemisphere. We did capture EPC on the right side with the electroclinical correlate, and essentially the impression from the video telemetry data was that this would be compatible with the diagnosis of Rasmussen encephalitis involving the left hemisphere. And also, she had multiple EEGs, as you would expect for someone who's having so many seizures and over the course of years. And what we also saw was that there was a progressive deterioration in her background EEG as well over time. And the seizure burden was getting progressively higher. So she had several anti-seizure medication tried, none with any consistent response. She also had high-dose corticosteroids initially in pulses, and then she had a long-term steroid treatment. She was treated with IV immunoglobulins, and also she had a treatment with azathioprine as a steroid-sparing agent. And on azathioprine, she had a relatively stable seizure control for about 4 to 5 years. I'm going to show you some interesting language fMRI data. So this was fMRI done testing for language, and what you're seeing, I think probably coronal is the best one to appreciate. So unlike the standard conventional radiology, so for fMRI, this is left side, and the one on the right is the right side. So in the first language fMRI, we see that the main kind of area that is lighting up for language, for expressive language, was the left hemisphere, and there wasn't any much kind of a bold signal on the right side. And so this was in the beginning, and the second scan done a year later, what we see is that now there seems to be more of a signal coming from the right side as well. So there is signal on the left side, but also there is kind of more increasing kind of signal being picked up from the right side. And further down, there was not much signal on in the left frontal region. The majority of the signal was coming from the right side. So for us, at the time, without knowing a lot about how to interpret language fMRI findings in this context, we were kind of maybe falsely reassured that maybe the language is being kind of more is being picked up and represented in the contralateral hemisphere. So even if she had surgery, maybe she will not take a big hit. I mean, as you know, one of the bigger concerns with left hemisphere pathology is language dysfunction if you do hemispherotomy. So in a way, we were kind of hoping that this means that her language will be relatively intact if she had left hemispherotomy. Anyway, so her seizure control deteriorated from the age of 11 years, and she had a significant worsening of the right-sided EPC. And the hemiplegia was getting worse, and she had loss of right-hand function. Neuropsychological assessment showed preserved non-verbal intellect, but her verbal intellectual function was plateauing. And because of all these reasons, and she had a significant impact on quality of life, she went on and had a left hemispherotomy 8 years after disease onset. So post-operatively, she had actually pretty good seizure outcomes. So she had significant improvement in seizures. She had no daytime seizures, and she only had some intermittent jerking affecting the right arm only from sleep. So she basically stopped having EPC. She stopped having the bigger convulsive seizures, and she stopped having the drops, which is fantastic. But when we look at the neuropsychology assessment post-operatively, non-verbal abilities, she was, in a way, there was plateauing of non-verbal and verbal abilities. And she had severe receptive and expressive language disorder and severe word finding difficulty. So this was the thing that we were most worried about, that she will have a significant hit to her expressive and receptive language. And although we were kind of reassured that by the changes that we had seen over longitudinal functional fMRI, despite of seeing those changes, which were encouraging, she had a significant hit to her language. So that's the case. Coming to Rasmussen syndrome, you probably kind of heard about and know about Theodore Rasmussen, who's from Montreal in Canada. And he first described a series of patients in 1950s, which was published in 1958, as a rare chronic encephalitis of the brain with an incidence of about 2 in 10 million annually. So this condition is characterized by inflammation and progressive unihemispheric atrophy. Usually there are kind of bilateral cases that are being described. It's a bit controversial whether these are really Rasmussen cases or are these kind of other conditions that we are basically lumping them together as Rasmussen, and we don't know what's going on with those patients. But yes, at least in literature, there are some bilateral Rasmussen cases being described. And clinically, these are characterized by pharmacoresistant focal epilepsy, progressive hemiparesis, and cognitive decline, as we saw in the case that I described. So these are the current criteria. These were proposed by BN and published. So basically, you have what we call as Part A and Part B, a part of the criteria. So you have clinical component, which basically consists of focal epilepsy with or without epilepsia partialis continua and unilateral cortical deficit. And on EEG, you're looking for slowing and discharge epileptic activity on the unihemisphere. And on MRI, you're seeing cortical atrophy with either abnormality in the gray or white matter or caudate atrophy. In Part B, you have EPC and progressive unilateral cortical deficit. And on MRI, you have progressive focal cortical atrophy, or the third kind of component of the criteria B is histopathology, where you see T-cell dominated encephalitis with microglial cells and reactive astrogliosis. So it is proposed that you should have all three criteria of Part A, or at least two of the three for Part B, to make a diagnosis of Rasmussen encephalitis. There's a problem I have with the current criteria is that, as you kind of seen, by the time a person meets these criteria, it's already too late. It means they already have established hemiatrophy. It also means they have established hemiparesis. So by the time you diagnose using the current criteria, it's already too late. So when you look at the pathology in Rasmussen syndrome, there is no pathognomic pathology. However, there are certain features on histopathology that could give you a clue. And if you see that, that is more consistent with the diagnosis of Rasmussen's are, as I mentioned earlier, microglial nodules and perivascular cuffing of T lymphocytes, so clustering. So those are the things that you see. Depending on the stage of the disease, you may see minimal inflammation, and then there will be a lot of inflammation. And then as the disease progresses, there's almost like a burnout phase where you would not see too much inflammation, but then you start seeing gliosis and atrophy, as you would expect with progressive inflammation. Coming to etiology, so over the years, it's an enigma. So we don't know so many things. I mean, it's been described for more than nearly 70 years now, but we still know very little about this condition. So we still don't know what causes Rasmussen encephalitis. So there have been various theories put forward. One of the theories was initially everyone kind of thought this is encephalitis, so it has to be infection. So those were kind of looking at viruses and bacteria. And although there were some source signals that were being published in the beginning, there is nothing consistent to say that this infection is associated with a development of Rasmussen encephalitis later. The second hypothesis is inflammation. So similar to other autoinflammatory conditions or immune conditions, you have some infection triggering an inflammatory cascade that leads to autoimmunity and destruction of the brain cells. There is some evidence to support that, in that we get in about 40% of patients with Rasmussen's, we have positive CSF oligoclonal bands, which indicate there is intrathecal synthesis of antibodies in these patients. So maybe it is possible that there is ongoing inflammation against some antigen that we haven't identified yet. Then again, further evidence for immune mechanism is the microglial nodules and T-cell migration into the parenchyma during the course of the disease. And there's also some interest about multiple hit hypothesis. You might have seen a couple of papers more recently where the authors have published evidence of focal cortical dysplasia in patients with Rasmussen encephalitis. So as a dual pathology. So the question there is this just an incidental finding that someone who's got a focal cortical dysplasia and they also have inflammation that's unrelated to that? Or is there a possibility that for whatever reason you've got a malformation of the brain and there is some kind of immune mechanism wherein the immune system goes haywire and then it starts attacking its own cells? So again, it's something that needs exploring, but that's all we know at this point. Coming to natural history. So you have, usually we describe Rasmussen as a three-stage disease where, with a prodromal phase where there is not a lot happening. You have some non-specific features, usually in the first 6 months of the condition. You may have infrequent epileptic seizures. Most of the times they are reported as having either focal or bilateral seizures, and then not really fixed neurological deficit. They may sometimes say that after a seizure they have a Todd's paresis, which might kind of last for a bit longer. But apart from that, the presentation is quite mild and not alarming at that stage. Then they go into this explosive acute phase, which can last for a few months to years, where suddenly on this kind of backdrop, they start having lots of seizures. EPC comes up, and then you start noticing progressive hemiparesis. There is cognitive deterioration. And if the dominant hemisphere is involved, you kind of get aphasia or language impairment, and hemianopia might kind of develop as well. And then they enter chronic phase, where it's almost like a burnout. So you have hemispheric atrophy, you have permanent neurological deficit. The seizures may not be as problematic as they are in the acute phase. In a way, it's kind of a burnout phase of the disease. And accordingly, the clinicians who have observed these patients or group of patients have kind of described there are two types of patients. One are what we call as fast burners. Usually they start early, around 5 to 6 years of age. They have a high seizure burden. Very quickly, they progress to EPC. They develop hemiparesis and language deterioration and cognitive deterioration very fast. And the atrophy of the brain happens very fast. So hemiatrophy of the brain happens very fast. So these are the fast burners. And then you have the second type, which are the slow burners, who are basically the ones who start quite late, usually in adolescence or early adulthood. The seizures are less frequent. The cortical deficit is, the atrophy is much, much slower compared to what we see in early childhood. And we see this in, like, when we talk to adult colleagues, they tend to kind of see more of slow burners. And we in pediatric practice tend to see a lot more of the fast burners. So coming to the management. This is probably one of the most difficult aspects, is kind of deciding how to manage these children. Obviously, you're managing the seizures, you're providing supportive care. Then the decision about immunotherapy versus surgery is the most difficult one. So generally, most of us, when we see a new patient with Rasmussen, we made a diagnosis, we treat with anti-seizure medication, and pretty much everyone kind of goes with immunotherapy in the form of a broad spectrum steroid treatment. And then depending on response, you decide whether you want to use a steroid sparing agent, immunoglobulin, et cetera, or whether you go for hemispherotomy. So general principles are, if there is a low seizure burden, if it's a dominant hemisphere that is involved, not a lot of deficit in terms of hemiparesis, the disease is slow progressing and late onset. So the slow burners that I mentioned in the previous slide are maybe in those ones you would consider immunotherapy, because if you operated and did a hemispherotomy in this patient, there is more to lose than gain, because they're going to lose function, they're going to have significant hit to their quality of life. On the other hand, if the patient is presenting with very high seizure burden, as was the case in the girl that I presented at the beginning of this talk, where there is EPC, progressive deficit, cognitive decline, and this is controversial, whether there is involvement of the contralateral hemisphere. So you started off with your unilateral or unihemispheric abnormalities, and the EEG kind of starts showing abnormalities on the other side. Does that mean that the disease is progressing and there is a risk that the contralateral hemisphere function might be impaired, having an impact on overall quality of life? So I think that's when you kind of need to make a decision whether you want to persist with immunotherapy or you would want to go on and offer hemispherotomy at that stage. So medical management. This is a nice cartoon from one of the systematic reviews that was done by colleagues from French colleagues. So as I mentioned, the first line therapy usually is broad spectrum, which is corticosteroids. Over the years, colleagues have tried different immunotherapies. Plus, the IVIG is one of the other kind of commonly used immune therapy. Plasmapheresis has been tried in patients both with the idea of basically removing antibodies. And there's also kind of some data on use of rituximab, basically inhibition of B lymphocyte function. And more recent, not more recently, I think, then the other mechanism is the T cell activation. So you're trying to inhibit lymphocyte proliferation. So the drugs that are used for that are tacrolimus, azathioprine, mycophenolate. All three of them work in a similar way. I think each center have their own preference of which anti-T lymphocyte agent they're going to use. In our center, we've got the most experience with azathioprine. I'll show some data on that. But there are other centers who prefer to use mycophenolate or even tacrolimus. More recently, there is interest in natalizumab. Basically, this is an agent which prevents or stops the lymphocyte kind of migration. It basically blocks the transfer of lymphocytes from through the blood-brain barrier. So the advantage of that is that you have very little systemic side effects, and the effect is supposed to be mainly on the brain. And you have kind of anti-cytokines. We are aware of anakinra, which we tend to use more and more in patients with fires. And then there is kind of more interest in anti-TNF alpha agent, which is adalimumab, which is more recent. There are very few case reports about the use of anakinra, adalimumab, and natalizumab at this stage. But most of the data we have is from earlier studies looking at IVIG, rituximab, and some data on azathioprine mainly. So this data is from the systematic review I mentioned, and what this shows is that although most of the agents are beneficial in some, there is no universal response. So they are partially beneficial, and the more important conclusion from this review is that even when they work, the therapeutic effect is temporary in that it doesn't stop the progression of the disease. So it is basically prolonging it's basically prolonging the inevitable, which is hemispherotomy. And that's what we showed in our kind of in the paper that we published on the use of azathioprine in children with Rasmussen encephalitis. So what this data shows is that those patients who had received azathioprine, basically it took longer for them to develop EPC, longer for them to develop hemiparesis, longer for them to progress from the disease onset to hemispherotomy. So all we kind of did was basically shift the timing of hemispherotomy from time A to time B. So none of them had control of the disease to the extent that there was no kind of progression of the condition, and immunotherapy was sufficient. Probably the data will be different for late onset and adult onset Rasmussen for the reasons I described earlier. And also it depends on how aggressive you are as a center. I think there are some centers who are more conservative and they would prefer to treat with immune therapy for much longer. Whereas in other centers like ours, we are a bit more aggressive with surgical management. The reason being the other kind of justification for doing a surgery early is whether you can tap into the neuroplasticity aspect of the brain, and if you operated them earlier, whether they have better outcomes in the long term because of neuroplasticity. So surgical management, the preferred surgical treatment is functional hemispherotomy. I don't think anyone does anatomical hemispherectomy these days, so functional hemispherotomy is the preferred surgery. And if you look at the data, I think the seizure-free outcomes are seen in about 50 to 86% of cases. Obviously, it depends on the duration of follow-up. So if you look at the studies that are shorter follow-up, you get higher numbers, so better favorable results. And the longer you wait, the seizure-free outcomes are kind of lower. It also depends on completion of disconnection. So if you've done hemispherotomy on a patient with Rasmussen or any, for that matter, any condition, and the seizures are ongoing, you're going to go look back and to check whether the disconnection is complete. If not, you would consider redo hemispherotomy if there is a connection that you can see, or that you could make an argument of doing anatomical hemispherectomy to basically remove the hemisphere with making sure that there is no connection left behind, but it has its own complications like hemosiderosis and hydrocephalus that you need to be aware of, but it's something to consider in refractory cases where you don't get a good outcome from hemispherotomy, functional hemispherotomy. So yeah, this I've already mentioned as to how do we balance about medical treatment versus surgery and hemispherotomy. So for the next 5-8 minutes, I'm going to talk about long-term clinical outcomes. This is the data we haven't published yet. So we basically looked at what was the longer-term outcome. So this data is based on 32 patients who have Rasmussen encephalitis, and so of them, nearly half of them, 15 of them had left hemisphere involvement, and 17 of them had right hemisphere involvement. Of the left, 11 underwent surgery, and of the right, 15 underwent surgery. The mean seizure onset was 7 years, and the time to surgery was about 11 years. So these are the seizure outcomes. So the longer you wait, then the seizure-free numbers kind of drop. So at 1 year in our cohort, we had 84% seizure-free. At 5 years, 80% seizure-free. 10 years, 73% seizure-free. And at 15 years, they were like about 55% seizure-free, which is really good numbers, actually, considering the duration of follow-up in these patients. Obviously, the ones who did not have a surgery, they all continue to have seizures. But as I said earlier, we are a lot more aggressive, and we do kind of do more hemispherotomies compared to some of the other centers. So the majority of our patients actually had hemispherotomy. And well, needless to say, surgery was the only independent predictor of seizure freedom. And we didn't kind of see any other significant variant that would predict whether the patients continue to have seizures or not. And at follow-up, those patients who had surgery, as expected, were either not on anti-seizure medication or having fewer anti-seizure medication. This is very interesting data. So we were kind of, in addition to looking at seizure-free outcomes, we were interested in kind of seeing what happens to their motor function and to their language function. So in the majority, irrespective of whether they had surgery or not. So this is slightly confusing. So this is the data for the full cohort. I don't know whether you can see my arrow or not. And then in the middle is the surgical cohort, which is 26 patients. And on the right-hand side is the non-surgical cohort, which is 6 patients. So as expected, you would expect that anyone who's had hemispherotomy would have significant impact on the function, but they were still able to use their kind of arm reasonably well, mainly as a helping hand. And the lower limb kind of function wasn't too bad. They were either able to, the majority, about more than a third of them were able to walk independently, and about 60% of them were able to walk with support, and only 1 of 26 patients was not able to walk, and they were using wheelchair. But in the non-surgical cohort, even though they had kind of worsening of function, these 6 patients were able to kind of walk independently, which again is probably a reflection that these are the ones where they were like the slow burners, and therefore the disease progression was slower in them. The second aspect we were keen on kind of finding out is what happens to the language function. So these are the 26 patients in the middle who had surgery, and 6 on the right side are the non-surgical cohort. And within this, we have got left hemisphere and right hemisphere. So those who had right hemisphere Rasmussen encephalitis, all of them had normal function, normal language function. So they were able to speak normally because this was a non-dominant hemisphere involvement. In those who had surgery, who had left hemisphere involvement and surgery, the majority were able to either speak reasonably well, or they were able to speak full sentences, but it was a bit difficult. And then 3 of them were able to speak in phrases only. And the interesting thing are the non-operated ones. So here we had 4 patients with left hemisphere Rasmussen who were not operated. And as we can see, even though they were not operated, when they were followed up, none of them had normal speech. And similar to surgery, they all kind of had a significant impact on their speech. So this data indicates, I know it's a small sample size. I think that's why we're trying to kind of collaborate with other centers to try and see whether we can collect more patients who are not operated and have had non-dominant hemisphere involvement, to kind of see whether this signal is kind of holds true even in a larger sample, because that kind of indicates that irrespective of whether you do hemispherotomy or not, those with dominant hemisphere involvement, eventually their language function is going to be very much impaired, in which case then you don't have to wait long for or kind of not offer hemispherotomy, because they probably will have a better outcome if you operated them earlier, not just for a seizure outcome, but also cognition. And there is some data from our group that shows the longer you wait after surgery, your cognition improves. So what are the challenges? The first big challenge is what is effective immunotherapy. So we looked at all the agents that are currently used for treatment of Rasmussen's, and we kind of know that, yes, some of them are effective, but they are effective only as a temporary holding therapy, and there is no cure. It's just it's a symptom management, and then maybe it prolongs the inevitable hemispherotomy. Then it begs the question, is that because we are diagnosing these patients late? And if we were to diagnose these patients early, and if we had effective immunotherapy, would that slow down or halt the progress of the disease and prevent us from kind of needing hemispherotomy in the long run? I don't know the answer to that question, but it's a valid question to ask. Following on that, from that, you can ask the question, do we need to revise diagnostic criteria that we're currently using? My kind of instinctive answer is yes, we do need to, but the problem is, what else are you going to use as a biomarker? What criteria are you going to use to make a diagnosis? So we need to think about biomarkers that we can use for early diagnosis of Rasmussen. Then the next kind of a challenge or controversy is timing of hemispherotomy. So especially in dominant hemisphere Rasmussen for optimal language outcomes. So for example, in the patient that we saw, would it be better if we had operated them earlier, as soon as you see them? I mean, there is no kind of clear age criteria, but generally we say maybe before the age of 6 or 8, if you operated, maybe they will have, you make use of the neuroplasticity and they might have better outcomes compared to someone who you operate when they are 10 or 12 or 15. So it's a difficult dilemma to whether you kind of operate early, go in, be brave and operate early and hope that they will have better outcome, or you wait out with immunotherapy, but then you end up kind of operating when they're older, and then the outcomes might be much worse. And the other kind of a challenge that I'm going to bring up is the reliability and value of language fMRI in predicting language outcomes. So we are kind of collecting this data on a wider number of patients in our institute. So we're hoping to kind of see if we look at a much larger group of patients, whether we can answer this question. And in the future, when we see that there is a signal that the language might be transferring to the other side, is it real, or is it a desperate attempt from the non-dominant hemisphere to try and take on some of the function from the failing left hemisphere? And but it might be trying, but it's not effective a transfer of a function. So we recently did a survey, international survey, looking at the practice in diagnosis and treatment of Rasmussen syndrome. And we had 112 participants from 6 continents completing the survey. And what we saw was that there was significant variability in clinical practice for considering diagnosis, and especially for medical management. And but everyone the majority agreed that functional hemispherotomy was the surgical procedure of a choice. And therefore, the conclusion from the survey was that at the moment, based on the data that we have and the literature that we have, it's not possible to make evidence-based decisions. And because of this kind of heterogeneity and inconsistency in practice amongst centers and amongst colleagues from across the world, it would be useful to have an expert consensus, which we are currently undertaking. So we are in kind of phase 2, round 2 of Delphi consensus at the moment. Hopefully, by the end of this, we will come up with some recommendations for diagnosis and treatment of Rasmussen encephalitis. And finally, I'm just going to mention a couple of projects that we are doing in our institute. So with my colleagues, one of the studies we're doing is looking at longitudinal imaging changes in patients with Rasmussen encephalitis, looking at volumetric data, and also looking at the function about neuroplasticity and how does the function evolve with the progression of the disease. And the second kind of study for which we have applied for funding, and hopefully we will get that to address very fundamental questions that I asked in terms of the etiology. One is whether there is an underlying subtle cortical malformation that is triggering inflammation, and then they end up having the atrophy that we see, whether there is a genetic susceptibility to immune dysregulation. And we are hoping to look for some biomarkers in brain tissue, CSF, and blood, looking at transcriptomic data, looking at DNA methylation profile, and we're going to do FIPS sequencing to look for antibodies against kind of antigens that might help us. So there is some very kind of we're hopeful that we have about more than 30 Rasmussen hemispherotomy samples, and hopefully with those numbers and using the right techniques, we might be able to answer some of these questions, if not all. So yeah, we'll have to kind of wait and see how things progress over the next few years. But what's interesting is all of a sudden there is a lot of interest, a renewed interest amongst colleagues from all around the world. In the last kind of 3 months, we've had so many meetings with colleagues kind of approaching us to collaborate. So hopefully with this new impetus and interest, we might be able to make some progress that we haven't done in the last 70 years. So I'm just going to thank my colleagues at Great Ormond Street Hospital, the whole of epilepsy surgery team, and special thanks to Marius, who's a colleague of mine, who worked together on the immune, on Rasmussen and FIRES. Torsten is a professor in UCL, and again, we are working together on Rasmussen patients, and Helen Cross and Sophia Varadkar, they kind of started collecting data since 1990s. So they are kind of primarily responsible for us kind of now having nearly 90 patients with Rasmussen's, which is probably the one of the biggest, if not the biggest cohort in the world at this point. So with that, I'm going to stop and we can have a discussion.
Yeah, thank you, Dr. Suresh, for such a lucid, descriptive talk, which has covered all the areas, including all the ambiguity in the diagnosis and the management challenges and the way ahead for the research purposes for this particular entity of unihemispheric syndrome. Now I invite our guests, the experts. We'll start with Dr. Maya Thomas. Dr. Maya, ma'am, your expert comments and your opinion.
Thank you, Dr. Suresh, for that very exhaustive presentation. Just a couple of comments. One is, as you have rightly mentioned, they present with motor seizures, which tells us that the onset of disease is predominantly peri-Rolandic. And we do see that situation where they predominantly present with opercular seizures and subsequently, focal motor or even sensory seizures. What we have found in our series was that the occipital lobe rarely gets involved. Of course, in the late stages, of course, the entire hemisphere is involved. So that was one comment. The other thing is, as we understanding the response treatment, obviously, definitely there is an immune dysregulation in this entire syndrome. So immunotherapy seems to be working, though eventually one has to go for a surgical treatment in the final stage. But I think with the ILA have brought in this etiology of immune-mediated epilepsy, I think early diagnosis is very vital. Where when a child presents with a sudden onset of acute seizures, predominantly motor, with preserved awareness, not fitting into an electroclinical syndrome, that could be an early marker of Rasmussen's, especially in all these what you mentioned as a slow burners. We don't see that in early childhood. We see that in a little in the later childhood or maybe in early adolescence. We see these where they present with, and these are what we call the immune-mediated epilepsies. They are often, not often, almost always they are seronegative, and these may be the early onset of Rasmussen's. And it's important to pick them up at that time because, as you have rightly mentioned, by the time you have Rasmussen's encephalitis diagnosis with all the diagnostic criteria, they've already developed focal deficits and hemispheric atrophy. So I think early diagnosis is very important, and hence the ILA having brought in this immune-mediated etiology is very important for people to recognize and initiate treatment. The other thing is about the timing of hemispherotomy. In addition to the language, which is of the function of the left hemisphere. Whenever there is again early involvement, when there is fairly preserved motor functions, that again is you cannot actually go in for a such a
drastic surgery such as a hemispherotomy. So that is losing a motor function to almost grade 0. Of course, they tend to recover to a large extent, but a child who's fairly with very subtle hemiparesis, that again in with the disease involving the right hemisphere, it is not just the language, I would say, it's the preservation of the motor function that is that the child has is also, you know, a factor for considering surgery. That is the reason, one of the reasons why we tend to push surgery, you know, because of the, you know, fairly preserved motor functions. We tend to push surgery to a little later date, hoping the child would kind of respond to immunotherapy. Other thing is, what we see is in a small group of patients, we do see the dystonic form of Rasmussen's encephalitis, where there is progressive caudate and putaminal involvement, and the seizures are actually, you know, far and few, so that is again another form of Rasmussen's encephalitis, and those children are actually very difficult to follow up because meaning do you offer hemispherotomy for them? And in most cases, what I have meaning what we follow is we just continue with the immunotherapy, and somewhere along the way the disease kind of stabilizes, of course, with significant morbidity in the form of dystonic hemiparesis. Yeah, that's it. Thank you.
No, I totally agree. I think that's why it's even more important to look at long-term outcomes, isn't it? Because what happens usually is we see them in pediatric, and then once they get into adult age, they are lost to follow up, and we don't really know what happens to them in the long run. And one of the questions is, are we doing the right thing by not offering? I'm not saying what we're doing is right. Whether if we looked at them maybe 20, 25 years after the disease onset, whether how much of a difference there is between those who had kind of surgery and those who did not have surgery, and what's the and I mean, I completely agree with you with regards to the motor function as well, because I mean, what we say in our kind of epilepsy surgery discussion is the thing that determines whether you offer surgery or not is the quality of life. So how bad are the seizures? If the seizures are stopping you from getting out of bed because you're dropping all the time, or, you know, if you're having almost very, very frequent seizures, you can't do any meaningful function, then I think then you could potentially kind of justify I mean, obviously it's usually more of a problem in the older children, isn't it? Where they are able and they are so conscious and aware of what they're going to lose if they had hemispherotomy. And that's what we kind of say, take into consideration. The biggest factor is the quality of life. How are we going to change that? There's no point in stopping seizures and making the child hemiplegic, and they kind of regret having the surgery, even though they're not having seizures. They don't want to have a fixed deficit, which is with them all the time, isn't it?
Yeah, absolutely.
Yeah, thank you, ma'am, for the insights and for sharing the experiences of yours. Now I invite our next expert, Dr. Atin, for the diagnostic challenges, which if he would like to mention his opinion and expert advice.
Yeah, so a wonderful talk, Dr. Suresh. I personally gained a lot from your experience. I learned a lot today. And as has been already highlighted, a lot of MRs come to us for a diagnosis, suspected diagnosis of Rasmussen's encephalitis. The findings are not very specific. A unilateral atrophy, if shown in the right clinical context, supports the diagnosis. But we know there are a lot more causes of unilateral atrophy rather than just pure Rasmussen's encephalitis. According to us, a lot of our residents jump to make a diagnosis of Rasmussen's based on the radiology alone. This will never fit in, as there are the clinical diagnostic criteria. So in the right context, seeing a unilateral atrophy helps. Of course, specifically what we've seen with our experience also, in the initial stages, the diagnosis is even difficult because there may be subtle changes on T2 weighted or FLAIR images in the cortical, somehow in the subcortical white matter. It's usually more described in the frontal lobes, temporal lobes, or the insular peninsular cortex, with some of the articles saying that caudate is one which is slightly earlier involved, as was shown in a case of Dr. Suresh also, in the first index case which he was showing. Having said that, those are again sometimes non-specific findings, but in a child with focal seizures or a gradually increasing onset of hemiparesis, even those changes typically help us to make a diagnosis. The diagnosis becomes easier when you do see definitely hemispheric atrophy, but you have to clinically differentiate from other causes like HHE or even a congenital hemiatrophy or a hemiatrophy secondary to other associations like sometimes in Sturge-Weber syndrome also. All those can lead to, and the radiology role is also important to rule out other causes for focal epilepsy and support the diagnosis of Rasmussen's. And we often need actually serial imaging. That's way more helpful in making a diagnosis to show a progressively increasing hemiatrophy, which literature says can take from as early as few months, the rapid course which you were showing, to slow insidious course, which actually can take sometimes a year or more to show even onset or gradual increasing atrophy from signal changes which are seen initially, subtle signal changes. If you've caught at the time of the acute inflammation, exact acute first inflammation. So that's, I think, my experience.
Thank you, sir. And now we invite our expert from Turkey, Dr. Ebru Arhan, for her comments.
Thank you, Dr. Badal. And first of all, I would like to thank Dr. Shefali and your whole group for inviting me as an expert and giving us the chance to present our case. Dr. Parwana will present our case, and I'll be happy to hear about our case's treatment protocol. It was really an excellent talk, Dr. Pujar. Your case was excellent, and also I learned a lot from your fantastic talk. And I think there's nothing left for me to say, as I said. After your valuable insights, it will be better to talk about the challenges, I think. As Dr. Atina said, the MRIs could be challenging in the early phases of the patients. In the early pages, as we all know, when there's no epilepsy epilepsy continuo, the diagnosis is challenging, and this is more evident in the pediatric population also. And the neuroimaging abnormalities can be interpreted as normal, maybe, and sometimes unilateral cortical deficits without epilepsy epilepsy continuo can be diagnostic, and it's worrisome. That may lead to overdiagnosis of Rasmussen encephalitis with the unilateral cortical deficits. And I agree with Dr. Pujar that we need some biomarkers, maybe immunological markers, and radiological markers for epilepsy, for Rasmussen encephalitis. And one other thing that I would like to focus on as a pediatric neurologist dealing with epilepsy and specialized in epilepsy and epilepsy surgery is that the delay of the surgery in cases with definite cases. Immunotherapy is just a bridge, maybe, in my opinion, to until surgery, a bridging therapy. I don't know if you think the same, but we start with immunotherapy, but we don't have. We should, as early as possible, go with the hemispherectomy, with the operational phases of the patients. I think the earlier phase of the study, hemispherectomy is usually the most indicated therapy, and I think, and in the acute and later phases, surgery is often contraindicated. Therefore, immunotherapy are recommended at that phase of the disease, and prodromal therapy. And I would like to summarize with that: we should do the surgery as soon as possible if we are really definite about the diagnosis of Rasmussen encephalitis. Thank you.
Thank you, Professor Hassan. Would you like to add after an excellent talk by Dr. Suresh and wonderful comments by our esteemed panelists? Would you like to say something, Dr. Hassan?
Yeah, thank you very much, Dr. Shefali. Dr. Suresh, thank you very much. Excellent talk. I'm agree with you. We have to need to revise the diagnostic criteria for the early immunotherapy. I think today the immunotherapy is the mainstay. I believe that we miss a lot of things. We are starting the late periods of the time during the Rasmussen encephalitis with the late definite diagnosis. Today we use just only one immunotherapy, then we start the second one. I think we have to apply multimodal approachment for the Rasmussen encephalitis. During the autoimmune encephalitis, we use the step-based. It is easily to follow up what's going on the cases, but in the Rasmussen encephalitis, I think there is a different immunopathogenesis, T cells, B cells, macrophages, and also there is going on ongoing neuroinflammation. I think during the immunotherapy step, we have to use the multimodal approach. For example, sequential therapy or maybe combined therapy with immunotherapy. It would be helpful to stop the progression of the disease. And what I would like to get your idea about to use the sequential therapy or combined therapy for Rasmussen encephalitis. The second point is that I think we need some biomarkers from the neuroradiologic side. You clearly mentioned that high resolution MRI and serial MRI examination, and also MR spectroscopic examination should be included for the diagnostic criteria, and also some neurophysiologic criteria, for example, transcranial magnetic imaging modalities to define the hemiparesis before the dense hemiparesis. You know, we as a clinician, we are waiting the hemiparesis. I don't know why we have to wait to hemiparesis to make a diagnosis. So I think neurophysiologic evaluation should be increased, for example, transcranial magnetic imaging studies. I would like to get your special idea. In the future, are we going to use combined immunotherapy for Rasmussen encephalitis for different immune modalities?
I think, yeah, early diagnosis, as you said, is the key.
Yeah.
And
yeah.
What we're doing increasingly is look at volumetric data on imaging. If you do kind of look at the volume on serial imaging, and if you kind of notice that there is progressive reduction in the volume of the hemisphere, that, and if it is in the right clinical context, I think that can give you sufficient evidence to make the diagnosis before you can see visually appreciable kind of atrophy of the hemisphere. Obviously, it's a challenge because I think not every center has got the capabilities to do kind of a 3D volumetric MRI, and more importantly, to have the software to be able to kind of do a volume analysis and time for the radiologist to do that. But because, I mean, even our center, where we get a lot of referrals, we only see maybe 2 in a year. So it's not a large number. So I think if we have committed team, it should still be possible to look at options to looking at volumetric data to kind of try and help with early diagnosis. And with regards to combined therapy, yes, I mean, that's the kind of idea. So I think it would be, I mean, with the available immunotherapy, we are not making much progress because we've been using steroids for so many years. We've been using all these azathioprine and all for so many years, and we haven't really seen any kind of better outcomes using that. I think what would be helpful is to see if from if we have a better understanding of the mechanism of what is causing the inflammation, and is the inflammation mediated by something else that we are not targeting with the current immunotherapy. And especially if you started the treatment earlier, and if you identified any novel therapeutic targets, it might be possible to get better outcomes. And if we think that it's just T cell mediated, or, you know, and if we use more than one T cell, anti-T cell kind of agent, I'm not entirely sure whether that's going to result, even if you combine therapy, it's going to result in better outcomes. Whereas if we understood the disease mechanism better, we might be able to choose better therapeutic targets. I don't think we are there yet.
Yeah, I would like to just inform everyone that we would definitely be having some great session in the AOCCN on Rasmussen's. So you keep tuning in, and somebody wants to put in symposia proposal. The last date is day after tomorrow, 31st. So you can still put it on. Yeah. Should we go on, Dr. Badal? You can just see if any pressing questions you can say right now, or we can have the cases.
Ma'am, I think most of the questions have been answered in the sessions as well as in the discussion part. Possibly we have the lack of time, so we can proceed directly to the presentations, ma'am.
No, but then you can go through all the questions, and
Right.
even the one what Ranjit has put, and you can ask what is missing should be completed, before
Yeah, ma'am.
9:30.
So the first question they want to ask whether you want to use IV methylpred or IVIG as a first line. Dr. Suresh?
I think most of us would use steroids first
Sure.
because of availability and cost. If you go to, it was interesting to look at the data from survey that we did. In the US, they have they use IVIG a lot more as second line, not first line, but second line. But in the UK, it's practically impossible to get IVIG kind of approved for conditions that are like Rasmussen, and it's super expensive. So yeah, I think I would go with steroids first line.
And one more question is like Rasmussen versus HHE. What is the minimum age at which RE can be diagnosed, and what is the reason for the unilateral involvement in Rasmussen's? I think that.
Yeah, I think it depends on the differentiation between Rasmussen and HHE depends mainly on clinical context, how they present and how quickly. It's a clinical story will give you one kind of diagnosis more probable than the other. And when I find out the answer to why one hemisphere is involved, I think I'll probably get a Nobel Prize.
True.
Or anyone who wants to investigate and answer that question, I think you're due to get a Nobel Prize. It's a question. I don't think there is easy answer.
One more question is from the radiological perspective. So I'll request Dr. Atin to answer this question. What is the early MRI feature? Is it the head of the choroidal atrophy or something else?
So different studies have actually shown different things, but any signal changes in the peri-insular cortex, insular cortex, frontotemporal lobes, gray matter, white matter have been described. Similarly, some other long studies have shown early changes in caudate. Caudate slightly being slightly more specific, early caudate involvement, but it is not that it is seen in all patients as far as I know from the literature review also, and as by my experience also. So we try to find, if we find it, we feel that maybe it supports, but often it's the insular, perinsular, frontotemporal, cortical, subcortical region. Maybe others, Dr. Suresh can maybe throw more light on this.
Yeah, it's perinsular is the first typical kind of early involvement. And again, I think it would be really interesting to look at longitudinal volumetric kind of data that might give a signal as to which is the part. I mean, is it consistent that in every or most, if not all, patients with Rasmussen, that the disease will kind of start in the same area and then kind of spread? So it will be interesting to see. So hopefully we are collecting that data. We might have an answer to that question.
Yeah, Dr. Suresh, one attendee has asked a question whether is there any utility of CSF findings in the diagnosis?
The only two things that, I mean, obviously you're using CSF rather than confirming the diagnosis of Rasmussen, you're using it to exclude other diagnosis. So I didn't go into the details about differential diagnosis. I'm thinking about other immune problems, thinking about, CNS kind of histiocytosis and, other, or mitochondrial disorder. So thinking about differential. So you're using it to exclude that. And the only kind of two positive things that you would typically see in Rasmussen's are, as I mentioned, about 40% of cases you have positive CSF oligoclonal bands. And then in some cases you have raised neopterins, which again, just a non-specific marker of inflammation.
Yeah. Okay, and one attendee has asked in this particular case vignette you have shown, she has in that context, he has asked, have you ever seen transfer of language in the Rasmussen patients with seizures starting after 7 to 10 years of age?
Again, I'm not entirely sure. I mean, the difficulty with these patients is that every patient is unique in a way. They follow their own course, and it's very difficult. Very recently, we've started collecting data on like longitudinal data on language fMRI. So it's going to take a bit of time to gather evidence to answer that question. But when is the cutoff? It's very difficult. I think the sooner the disease starts, the more likelihood that there will be transfer of language. But I think generally people say around 6 years is when you tend to kind of 6 to 8 years is when you kind of say, well, if you were doing surgery or it's if the disease starts before that, then there's more likelihood of the other hemisphere taking on function of the affected hemisphere.
Yeah, thank you, Dr. Suresh, for such a lively session and answering all the questions very patiently. Now we move on to case presentations. And to invite, first of all, as the rules are there, we have to start with military precision, that the timing is going to be 4 minutes for the talk and 1 minute for the moderator to moderate this presentation. So we'll first move on to the speaker, Dr. Parwana. She's from Ghazi University School of Medicine, and the moderator would be Dr. Ebro. Asmita.
Good evening, everyone. Thank you for inviting. Okay. Our patient, I will present. Our patient I will present is 16 years old female. Initial seizure occurred 2 months ago as generalized tonic-clonic. Levetiracetam was started. After 1 month, patient presented with epilepsy pulses continued. Anti-seizure drugs were ineffective. EEG normal. MRI report did focal cortical dysplasia in the left precentral gyrus. This patient was referred by Fulya Kürekçi with diagnosis of FCD for epilepsy surgery to our hospital. Medical and family history is unremarkable. Neurological examination revealed persistent rhythmic myoclonic of the right arm. I want to show some videos of patient. First video. And second video. Okay. Current anti-seizure drugs include levetiracetam, carbamazepam, lacosamide, clonazepam, topiramate, midazolam infusion, and gabapentin for pain. For differential diagnosis, was the hand movements epilepsy partialis continue? Was it tremor or dystonia with myoclonia? We accept these movements as epilepsy partialis continue. For differential diagnosis include Rasmussen encephalitis, vasculitis, FCD, subacute sclerosing panencephalitis, neurobrucellose, and paraneoplastic disorder. Laboratory results were non-pathogenic and negative. We observed patient 24-hour in our video EEG unit. As posterior dominant rhythm was observed as asymmetric. Left hemisphere was slower than right. For ictile, we observed continuous sharp waves in C3P3 electrodes, no buildup. And we observed left temporal slowing and left hemispheric sharp waves during sleep. MRI and MR angiography reported T2 flare hyperintense pathological signal changes in the left frontal paramedian region with focal cortical and subcortical white matter atrophy, mild volume loss in the anterior cingulate cortex, increased flare intensity in the left parietal postcentral gyrus with mild associated atrophy and slight reduction in the size of the left caudate nucleus head. We can see here hyperintense pathological signal changes and focal cortical and subcortical white matter atrophy. Here we can see increased flare intensity, left parietal postcentral gyrus. Associated atrophy and slight reduction in the size of the left caudate nucleus head. And the lack of atrophy even after onset of epilepsy parcels continue in Rasmussen encephalitis is rare. Mild caudate atrophy was present in our case, and we found a case presentation which was very similar to our case. Our treatment plan includes pulse steroid therapy for 5 days, monthly IV immunoglobulin therapy, and rituximab weekly for 4 weeks, and follow-up with cranial MRI scheduled for 3-6 months. And Rasmussen encephalitis is a rare chronic inflammatory brain disorder resulting in progressive neurodegeneration in one cerebral hemisphere. Etiology is unknown, but there is strong evidence for an immunopathogenic mechanism. Cases of clinical symptoms
Dr.
include
Parwana, sorry to interrupt. We are running late. Can you just wind up?
Okay. Why our patient is not focal cortical dysplasia? Focal cortical dysplasia is a malformation of cortical development. Seizures can start at any age, especially in first 5 years. And EEG is characterized for EEG is characterized fast activity, spiking for MRI, cortical thickening, blurring of white matter, gray matter, hyperintense of white and gray matter. And patient with drug-resistant epilepsy must be referred to an epilepsy center. Complement investigation, video EEGs, cognitive evaluation, brain imaging, therapy must include immunomodulatory therapy, and if pharmacological treatments fail, surgical treatment should be considered. Early diagnosis of Rasmussen encephalitis may allow to propose anti-inflammatory therapies before visible neurological deteriorations. And thank you.
Yeah, ma'am, Dr. Ebru, ma'am. We'll request Dr. Ebru Arhan, ma'am, to please.
Yeah, thank you, Dr. Wadel. Thank you, Dr. Parwana, for your case presentation. The challenging thing in this case was really the movements of the patients. I mean, was it a dystonia? We cannot move the videos due to the time restriction, but it was like a dystonic seizure, like a hemidystonic seizure. Therefore, at first we couldn't consider it as epilepsy process continue. Therefore, we had to investigate her a lot with both MRIs and everything MRI things. We also did the PET MRI, but we couldn't show it here now. And with the slight, very mild basal ganglia atrophy, caudate atrophy, we thought that this could be a Rasmussen encephalitis, and we started immunotherapy after that. With this patient, we would like to give the message that the diagnosis of Rasmussen encephalitis should be done as early as possible, and immunotherapy should be started as early as possible before the surgical therapies. Thank you for inviting us for this presentation.
Yeah, thank you, Dr. Ebru, and as Dr. Parwana very nicely presented, we move to the second case now. This second case is by Dr. Kavya, and the session will be moderated by Dr. Pradnya Gadgil. The team is from SRCC Children's Hospital.
You can have the expert comments on all the three cases in the end, right?
Yes, ma'am.
Or if any, or anything, or any of the experts, Dr. Suresh, any other, anybody else, even Dr. Atin and Dr. Maya want to add something, or Dr. Hassan, for this first case before we proceed. Maybe then they'll get confused between all the cases. We can have Suresh.
I just wanted to mention that there's a very nice paper published by our colleagues regarding differential diagnosis for EPC, which basically the three most kind of a common diagnosis for in a patient who presents with EPC is Rasmussen mitochondrial disorder and focal cortical dysplasia. So for the trainees, it's a really good paper. I'll put the link in the chat, but it's a really nice paper for you to read.
Thank you. We can go ahead with the second case.
Good evening, everyone. Yes, ma'am. Good evening, everyone. Today we are going to present a proven Rasmussen encephalitis case, who's a 6-year-old right-handed girl. She was a type 1 fast burner, and we are here mainly to discuss the radiological oddities in our case and also the challenging of operating in a dominant hemisphere, which could affect her language and motor. So, in interest of time, I'll keep the history and disease course short. At 4 years of age, she had the seizure onset, where she had prolonged right focal motor unaware seizures. So she was getting it on and off for a while and started with anti-seizure medications. So she was seizure-free for the initial 6 months, but later, which the next 6 months, almost she got worsened, both in terms of frequency and also with her right EPCs. So she required ICU admissions in view of focal status. Later, which she developed EPCs on the right upper limb, and she developed right hemiparesis also in the due course, but her cognition was intact. In spite of multiple anti-seizure medications and immunotherapy, her hemiparesis worsened, continued with EPCs, and even her speech started getting affected. So the oddities were, this was her first MRI, which was in January 2023, where we can see the altered signal intensity in the left superior frontal gyrus with no restricted diffusion, no cystic changes, no blooming. Which was suspected to be a FCD versus glioma. This is the corresponding T1 weighted and T1 inversion recovery sequences. After 6 months, when she presented to us, we had repeated her MRI, which showed significant left anterior quadrant atrophy. Surprisingly, the previous lesion got disappeared. So with this finding, and also there was blurring of the gray white matter in the left side anterior cingulate gyrus. So the possibility of Moge was there at this point. Later, which we had in multidisciplinary team discussion in view of medically refractory epilepsy in a dominant hemisphere. So the DDs were Rasmussen's or hemispheric pathology or any other autoimmune pathology, but all her CSF protein autoimmune panel and all those were negative. So we discussed the value of biopsy in this case, and her rate of progression was significant. Along with that, she was very high functioning. Her SQ was 110, but she developed ADHD and oppositional defiant behavior in that point. So with all these in background, we did some research in the literature review. Along with that, we did a PET brain, which showed there was mild cortical thickening in the same area where there was a previous lesion. I have to highlight this is a ictal PET because she was getting EPC throughout. And it showed hypermetabolism in the same region and moderate hypermetabolism in both the lobes. So during the reviews, we found a similar article where like most of these points have been discussed in the previous discussion. So it's a MRI mimicking FCD in early Rasmussen's encephalitis. So in this case, there was a lesion in the right parietal region, later which it got disappeared. PET also showed similar lesion in the right hemisphere, and bilateral hypometabolism, but eventually the right hemispheric atrophy set in and they went ahead with surgery. So we repeated one more MRI in the February 2024, which even proved the thoughts, which is showing significant left hemispheric atrophy. And by this time, she was clinically also worsening in a rapid fashion. So these are our points in favor of Rasmussen's, and the atypical patterns were like over epileptiform discharges were over the left posterior quadrant, and imaging was showing disappearance and the highlighted things. So this is the diagnostic criteria. She was fitting all the clinical criteria for Rasmussen's. So finally, we decided to go ahead with left hemispherotomy, and we counseled parents in detail. It took some time for us, and we explained everything about the post-operative complications, which could be global aphasia and dense right hemiparesis. So we went ahead with surgery in March 2024. Immediate post-op, she had no speech and no movement, but later which the therapies started. A post-operative MRI is this, and the HP report shows Rasmussen's encephalitis. So this is her post-operative video, where this is the 2 months post-operative video where she regained her speech. Now she is in the 7th month of follow-up. She is doing well, and thank you for the time.
Yeah, Dr. Pradnam.
Thank you so much for the opportunity. So this was a case to just highlight the challenges. A young girl presenting with a very explosive onset of focal seizures, along with, of course, motor deficit. The radiology put us off initially when she was clinically very difficult to manage as to, is this an FCD, is this something else, or is this really Rasmussen's? And I think the challenge lies in the discussion that's happening earlier this evening, that we don't have very great biomarkers which will tell us that this is Rasmussen's, which will help us take quick decisions with respect to disease-modifying treatments, especially in these kids who are the younger ones and who present with a very explosive onset of seizures, the fast burners as they are called. So that was also my question to Suresh, saying, are these patients, given the fact that you want to optimize on the potential for neuroplasticity, especially given that this was a dominant hemisphere Rasmussen's, would we think of surgery slightly earlier rather than later as compared to maybe the type 2 phenotypes? So that is what we ended up doing. Very difficult discussions with the family with respect to aphasia. So she had just hit 6 years when we operated, and she's regained her speech. We will do a detailed neuropsych in a year's time, but functionally she's regained communicative language, both receptive and expressive.
Yeah, Dr. Suresh or any other experts? Yeah, Dr. Suresh.
No, I agree. I think, I mean, the result kind of speaks for itself in a way, isn't it? That I think from the surgical sample, you've got the supportive kind of evidence that this is the diagnosis. And I think in these younger ones, when they present in this explosive fashion, I think it makes sense to go in early. And I mean, this is the observation that we've also kind of seen, that the younger ones, when you operate early, they tend to do well in terms of language function, and the motor function is predictable. We know what to expect following the surgery.
But that underlines the need for a biomarker in these younger ones to take a quick decision with respect to saying, I'm going to make you aphasic, is really a tough one even for the family to take. So that biomarkers might eventually help us take these difficult decisions quicker. So all the best to you for your study.
Bijoy has asked something, Praganya. Was immunotherapy tried in this child? Bijoy has asked, Dr. Bijoy.
Yes. So while she was coming and getting admitted, she had multiple anti-seizure medications, IVIG. I think they gave rituximab, if I'm not wrong. So that was happening in parallel, but the seizures were just unabated. There was nothing touching the seizures, really.
Thank you. Wonderful case from Turkey and wonderful case from you. Suresh, I think one question was not answered. Any role of plasmapheresis? Dr. Anjana Sajid has asked.
Again, no consistent response to plasmapheresis.
Thanks.
And just
Thanks.
one thing I
Madhav?
wanted to add to what Pradnya said is, I think Atin already mentioned earlier in his comments, is it's not unusual to kind of think initially that they have a focal cortical dysplasia because they've got this hyperintense lesion that when on the first scan, it might look like a focal cortical dysplasia. And then if you see a change in the character, I think Atin can correct me, but that might be one clue that this is not FCD, because on subsequent imaging, the hyperintensity changes, the quality of the lesion looks different. And with that, if you notice, there is some atrophy or kind of sulcal prominence, and we would definitely look at the caudate head. And if those two markers are present, I think then it's a clear-cut Rasmussen's.
Right, very rightly said. So if acute signal changes are seen, that's probably because of acute inflammation. Over a serial time, if the signal changes disappear, it kind of rules out focal cortical dysplasia, which is gonna show the same signal changes. So in that case also, the serial imaging showed that it was probably acute inflammation. That what we see in the time of Rasmussen's also, those early changes, which overall then progress to atrophy subsequently in those areas itself. Sometimes it could be seizure-induced focal edema also that can potentially be seen and misdiagnosed as a focal cortical dysplasia in those regions also, right?
So shall we move to the third case, ma'am?
Yeah, and 5 minutes. Yeah. And I think we crossed 4 minutes, but we can finish off by another 6 minutes or so. Yeah. Yeah.
So we invite the next speaker for the presentation, Dr. Harshruti Shah from Rajvi Hospital, Gujarat.
I think it's for Dr. Harshiti's student, I think. Or
No, I'm here.
okay. You'll be presenting
Okay.
yourself?
Yeah,
I
yeah.
thought you'll have a
Yeah.
student to present.
I'm
Okay.
presenting for the
Okay.
first time. I know.
Okay. That's what I was wondering. Yeah.
But the thing is, the case was so unusual that I thought that I should present, And unfortunately, I don't have a students like you. So I thought I myself will present the case. And so this was a patient. I'm just narrating the history in brief. He's a 3-year-old male who was born of non-consanguineous parents. And he had a first episode at 3 years of age. The semiology was typical, like he had a behavioral arrest, which was followed by the chewing of the lips, and there was a drooling from the mouth. And immediately after this episode, the child was too hyperactive. So there was a behavioral abnormality. The episode was very short, like it lasted for 20 to 30 seconds only. So the child was shown to the pediatrician. They started with oxcarbamazepine and they did an MRI. But thereafter, the seizures recurred, like in December 23, there were 2 more episodes. So the child was brought to me. And then I did the evaluation of the MRI. And that MRI was done from the outside, where it was reported as normal. But when I saw the MRI, I thought that there is something which is brewing on the right side. So there were 2 probabilities. One was FCD, I mean focal cortical dysplasia, and the other was a seizure-induced postictal edema. But the radiologist denied and he said that this is absolutely normal. So we did an EEG, and the EEG was showing because he had a seizure, and that was classical behavioral arrest, but it was showing a spike and wave discharges from the right hemisphere. And that was evident that this is the same area from where we are suspecting the abnormality. The same area is throwing the seizures as well. So we just, I just added clobazam and the child went home. But in January 24, that is within 1 month, the episodes became frequent. And here the semiology changed a bit. There was a tonic version of the head on the left side, and that was followed by the speech arrest. That was again transient. They thought that adding the oxcarbamazepine did not work much, so we had changed to the valproic acid. Child was better for 1 month. And in the next month, he developed a repeated episode of the twitching on the left side of the face. So we did a video EEG. This was a seizure semiology that he was having a twitching on the left side of the face. And he was trying to hold it because the awareness was maintained. When we did a video in EEG, it was showing a persistent epileptiform abnormality, which was coming from the right side, where there was gradual building up of a discharge. But by and large, the etiology, the seizures were confirmed that it is showing an continuous epileptiform discharge, sort of an ESES-like picture, which is coming from the right side. So with this picture, I added the steroids, and that was continued for 6 weeks. So initially, the child was seizure-free, and the cognition was also maintained. But on tapering the steroid on the 6th week, he developed the opercular syndrome. So the steroids we did not stop, but we continued in a low dose, but it did not help much. And he developed a weakness on the left upper limb. The mother also noticed that there were severe sleep disturbances and there was a behavioral abnormalities as well. The child was too hyperactive, using so many abusive words, and he was not into the control. And the moment he tried to go to the sleep, he was getting a staring look and he used to wake up. So he was not getting into the sleep. So that was mother's concern. And then they came to me. So I thought that there is some focal etiology. So we did a PET. The PET was showing a focal hypometabolism, which is again coming from the right side. And they did a fusion images, and that showed that there is a oliguria, which is there on the right side. So we just continued with anti-seizure medication. The 4th was added, including perampanel. But it did not help much. So I had a strong suspicion, a clinical suspicion of having a Rasmussen encephalitis, but the age was not fitting with that. So there was some dilemma. So with that suspicion, we gave a rituximab, an adequate dose, but there was no improvement. And thereafter, he had a persistent facial twitching, which lasted for more than 36 hours. And it did not respond to any of the anti-seizure medications which was given in the loading dose. So the MRI was repeated, and there the MRI showed some atrophy in the same region. There was a progression of the lesion within a span of 6 months, where initially there was some edema versus focal cortical dysplasia versus polymicrogyria, and here it showed some atrophy. And so there were 3 things. One, the child was too young. His cognition was maintained, but he had a refractory focal epilepsy, and there was a rapid progression of the condition in a span of 6 months. But along with that, he developed a weakness on the left hand. The PET was suggestive of hypometabolism in the right basifrontal cortex. And on interval MRI, we could see the focal mild volume loss over the right basifrontal cortex and the medial frontal region. So we thought that no way, because he is not responding, though it could be a Rasmussen, we should go for the functional hemispherectomy. So we advised for the functional hemispherectomy. That was done in June 24, and the report was suggestive of stage 1 Rasmussen encephalitis. So it was a very young child who was a fast burner, and he was to be operated because it turned out to be a Rasmussen encephalitis. And then following 2 months, he is having a left hemiparesis. The power is grade 2, but his language is well maintained. His cognition is very good. Contrary to that, this is another child. This is another patient who is an 18-year-old female. She was having an onset of seizure at 8 years. It was a focal seizure. Thereafter, the seizures were infrequent. So at 15 years of age, she had a frequent seizure. So she was on 4 anti-seizure medication, including oxcarbamazepine, clobazam, lacosamide, and she was seizure-free with those medications for 3 years. And then she developed a status epilepticus. So this was a condition when she developed a status epilepticus. She was having a classical opercular syndrome. If you look at her, she is having this movement, and there was a typical sound, that, and there was lots of drooling. So we repeated the MRI, and that MRI was, this was a MRI in 2015, and this was an MRI in 2021, where it showed some atrophy on the left side. There was some changes. There are some changes on the right side as well, But there were definite changes. I mean, there is an atrophy which is there on the left side. So it is a dominant hemisphere. Patient is stabilized initially with the pulse methylprednisolone, and thereafter with the second episode of status epilepticus, I gave the rituximab. She is seizure-free for 1.5 years, and again she has developed status epilepticus, and that appeared only when we tried to taper one of the anti-seizure medication. So her cognition is well maintained. There is no focal deficit. She is a vegetable vendor where she calculates the currencies accurately, and she is otherwise highly functional lady. So there were two contrast patients. One was a fast burner and other one is a slow burner. Here the question was, because she is a functional lady, she is in a marriageable age, she has a good cognition, there are no weakness, and there is some atrophy, and she is getting an occasional episodes of the status epilepticus. Otherwise, she is well stabilized with the 4 anti-seizure medications. Should we go for the hemispherectomy, and when? So thank you.
Thank you, Dr. Harshati. Thank you so much. Dr. Suresh. Dr. Suresh, you have to answer.
No, I think very interesting cases. I think, yeah, as you said, they're quite a contrast, isn't it? And I think I would have done the same thing in both the cases. I think the second one is difficult because she doesn't have deficit, her cognition is maintained. And I think, like we said earlier, she's going to get a much bigger hit by having a hemispherotomy and being permanently kind of hemiplegic, which would have a significant impact on her quality of life. And if she's happy to manage infrequent, I mean, they are status epilepticus, but I mean, there is, if they're happy to kind of manage that from time to time and bear with that, I think it would be the right decision to make. And she's one of the slow burners. So yeah, it's weighing the risk and benefit. And I think in this person, the risk of hemispherotomy and the consequence of hemispherotomy would be much, much higher and have significant impact on her day-to-day life, because she probably would find it very difficult to do what she's doing now.
Okay.
Thank you, Dr. Suresh. Dr. Maya, Dr. Atin, Dr. Ibru, Dr. Hassan, anything you want to add to this case? Then we will have your take-home messages from all, starting from Suresh, because he's the showstopper today. Thank you for wonderful cases, Dr. Harshati. Having both the opposite kinds was very interesting. Thank you. Look, Professor Ibru, anything for this case, or you want to give the take-home messages? Anything for this case, please go ahead. Professor Ibru, you can make comment on this case as well as give your take-home message, because we have 15 minutes past time.
Yeah, I agree. I agree with Dr. Yeah, I agree with Dr. Pujar. I think she will be good with hemispherectomy. I think I agree with Dr. Pujar about that for this case.
Thank you, Professor Ibru. So Suresh, your take-home message, because you are showstopper. You start with you. Yeah.
No showstopper. I'm a student of all of you guys. So all I want to say is diagnose these patients early, because it does have an implication on ultimate outcomes. So diagnose early and refer to centers where there is more experience available in managing these difficult patients, and there is need for research. So that, and these are extremely rare patients. We all kind of see 2 or 3 or 4, well, in a lifetime sometimes. So it's really important that we work collaboratively, kind of join hands and do some research to understand the condition better and hopefully have better treatment options in the future.
Absolutely. Thank you. Thank you for the amazing talk. So now, Professor Ibru, your take-home message.
Thank you. I think we have to get together with our cases and about biological and also radiological hints for this Rasmussen encephalitis patients, and we have to share our patients together. By this way, we could go with the treatment and the diagnosis of early diagnosis of these patients. That's all I'm gonna say. Thank you.
Thank you. Thank you. Dr. Atin?
Ma'am, everything has actually been covered and fantastic
Take
session
home
today.
message है नहीं take home message तो होता है.
So take home message is the radiologist works in close conjunction with the clinician. Can't make a diagnosis on my own unless it is a burnt out atrophy. The clinicians rely on us also, so we have to work together along with of course the clinical symptoms as supported EEG findings to make a diagnosis. So and we see the cases more deeply for subtle signs only if we have the correct clinical context, especially in early cases. And as told earlier, serial imaging definitely helps to make the diagnosis. So if at first time you're not able to make it radiologically, that's okay, you're treating the seizures, but repeat a scan closer to 1 month, 2 months, 3 months interval if it is a fast burner, and or later interval to support your diagnosis.
Yeah, and I must add on that, Dr. Atin has become an integral part of our child neurology division. So that is how close pediatric neurologists and neuroradiologists have to work. And he's also a neuroradiologist for many of our alumni. And he's doing online things for our alumni. So that is something you need to have a good relationship with, close coordination with your neuroradiologist, Dr. Maya.
Yeah, the only comment is I think we need to look carefully at the non-operated cases. What is their outcome? And especially with the newer immunotherapy being available, I seriously hope we don't have to go in for this very catastrophic surgery, which is hemispherotomy. So early immunotherapy and trying to control the disease with better immunotherapy. That is what I would, meaning we need to look at the, thank you.
Thank you. Thank you.
One short case is there, Dr. Chavis.
One short case is there? We've not finished?
No,
Achha, yours. Oh, so sorry. Okay, I'm so sorry, Mahesh. I forgot about it. I'm so sorry. I was winding up. So okay, so sorry. You get the case, please. I'm really sorry. Yeah, I'm really sorry. We'll give you 5 minutes. Yeah, is it okay? Suresh,
no,
sorry, we forgot there was a fourth case, and that is our secretary of AOCN only. I am so sorry. Yeah, please, please.
I'm really sorry. I was supposed to see a patient 15 minutes ago, so I'm going to.
Oh yeah, please, yeah, you can.
Yeah. Okay.
No,
really sorry. Thanks. Thank you.
Thank you. Thank you so much. Thank you. And we'll have a collaboration. That is so. Yeah, we'll definitely do. Yeah.
Well done, of course. Thank you. Bye bye.
Yeah. So we
good evening, everyone.
Dr. Chavi for the presentation.
Yeah, good evening, everybody. So I will be presenting Rasmussen encephalitis. Is there a role for medical management intervention here? So we had one 11-year-old male child who was born of non-consanguineous marriage. His perinatal and postnatal period were uneventful with normal developmental milestones. He came to us with complaint of multiple episodes of late focal onset seizures from the last 1.5 years. Seizures were in the form of aversive clonic seizures which lasted 3 to 5 minutes in duration and occurred once in 8 to 10 days initially. And seizures were predominantly seen in sleep and early morning. So now he complained of increased frequency of seizures from last 1 week. He had 10 to 15 episodes daily after inadvertent stoppage of anti-seizure medications. He also complained of paucity of movements of the left side of the body from last 1 week after increased frequency of seizures. He was taking sodium valproate, levetiracetam, and clobazam. MRI brain was done in June 2024, which showed bilateral hippocampal volume loss with subtle hyperintensities on the right side. On examination, he had power of 3/5 across all joints in the left side of the body, and right side power was normal. So routine labs were normal, and EEG showing this ictal rhythm was suggestive of right hemispheric epilepsy. And repeat MRI brain was done in November 2004, showing right hemiatrophy. So our differentials were Rasmussen encephalitis, Diet-Davidoff Mason syndrome, and HHE. So our patient fulfilled the criteria of Bayes criteria. So we studied him on tablet oxcarbazepine and pulse dexamethasone in view of high burden of electrographic seizures. His already ongoing levetiracetam was tapered and stopped. So keeping in mind the predominant role of T cells in Rasmussen encephalitis, Among available options, although relatively new immunotherapy for Rasmussen encephalitis, we considered adalimumab for our patient. So we gave him 2 doses of adalimumab at a gap of 15 days, and we saw a good response in the form of improved left hemiparesis with power of 4/5 across all joints in upper limb and lower limb, and decreased seizure burden in the form of only 1 episode every 12 to 15 days. So concluding my presentation, hemispherotomy, although the best option in Rasmussen encephalitis, but because of permanent sequelae like homonymous hemianopia, hemiplegia, and aphasia in case dominant hemisphere is involved, it makes parents hesitant to choose this option. So it's necessary to identify the potential pharmacological treatment options for the disease, and immunotherapy, potentially promising new therapeutic option. So in view of predominant role of T cell cytotoxicity in Rasmussen encephalitis, T cell modulation therapies like anti-TNF alpha should be tried at an early stage of the disease without delaying other approaches. Thank you.
Yeah.
Thank you, Chavi. In this case, actually, this was a slow burner, Rasmussen encephalitis, and we had tried rituximab in 2 of our earlier patients for about almost 3 to 4 doses, but we didn't get much response to rituximab. We thought of using adalimumab in this child, and in this case, within 2 doses, we got good improvement. Our questions here was how long should we use adalimumab, and what would be the end point, and experience about use of adalimumab in Rasmussen from other experts. Maya, ma'am?
I haven't used adalimumab,
Okay, ma'am.
Mahesh, but
Okay.
of course we've used rituximab and mycophenolate and azathioprine. Like I
Okay.
said, early use definitely improves the outcome for sure.
Okay.
And I think it's important to look at this particular cohort.
Okay, because what they say is it's more of T cell mediated response, ma'am. So adalimumab would be a
Yeah.
better choice rather than rituximab, which works mainly on B cell. So that was
Yes,
the
okay.
rationale for using adalimumab in this child.
Sure. Yeah, I think, with better immunotherapy, I'm sure the outcomes are going to be much better and
yes,
we'll see a different disease
Yes,
outcome.
ma'am.
Yeah, absolutely.
Thank you. Thank you.
Yeah, and thank you, Chavi and Mahesh. It was very, very crisp, the ones like we expect. And I'm really sorry. I had a
No
very
problem.
busy day. I forgot, the
No
autism
problem.
clinic. I just finished so now all of your certificates will be mailed to you, and we look forward for you to join us for the Asian Oceanian Child Neurology Congress in New Delhi from 17th to 20th, and a pre-conference. There are actually 8 workshops. 2 have been added to the one which is on the video. We've added neuroimmunology and we have added neuromuscular disorders, and there's going to be one post-conference as well, additional for the practicing pediatrician. So that is there. So we have 8, and you have your abstract submissions on, you have registrations on, you have symposia proposals on, and they are going to be there till 31st. And then you have some NeuroQuests which are there for some good videos you have for for movement disorders, some good videos you have for sleep, some good videos for sleep disorders, some we also want some snapshots and spotters, and also some enigmatic cases. Plus we will be having many more interesting cases will be sought out from the workshops. So we welcome you all to New Delhi. Yeah, you can end up, and I'm really grateful to you, and I can apologize to Chavi and Mahesh for oversight. Yeah, thank you. Thank you so much. Thank you all the experts. Dr. Hassan, are you there? One second, just stop the video once again. Dr. Hassan, you there? He's not there. Okay, fine. You can start the video. Yeah. Thank you, everyone. Bye.
Good night.
See you after 2 weeks. Good night. Thank you so much, Dr. Maya.
Thank you, ma'am.
Bye. Thank you, Badal. Thank you.